Welcome to Senadhipan Education Foundation. I am Dr. BaijuSenadhipan. I am the founder of Senadhipan Education Foundation. Knowledge shared is knowledge squared. We started this knowledge sharing program way back in 2007, and the brochure was the initial brochure was inaugurated by or released by Antonio Longo from Italy. Then we launched Senadhipan Education Foundation by releasing a set of educational DVDs in 2012 January. It was released by Seon Han Kim, a colorectal surgeon from Korea. Then after we had 6 months and 1 year fellowship programs in laparoscopy surgery in advanced and basic laparoscopy. We had contact classes, hands-on training, and with the advent of COVID, we started online programs in July 2020. The logo was released by Prof.Olle Ljungqvist from India. And then we started having live surgeries in online platform. We did the first lab anterior section in FB Live in 2020. And then we did a lab people in August 2020. Then the live lectures started with the world leaders like Prof.Olle Ljungqvist. This year, we are starting international fellowship program in laparoscopic hepatopancreatobiliary surgery, colorectal surgery, and upper GI surgery with the collaboration with the universities in Japan, France, and Korea. The applications are invited. We have a appearance in social media. We have almost 20 WhatsApp groups full of participants, and we have a Facebook group having 1,200 delegates. In the season 1, we had 28 webinars with world leaders, and we had a good global acceptance. More than 60 countries participated. This is one of the largest virtual platforms in the world. You can see the participation year 1,303 in a meeting from more than 60 countries. We have a YouTube channel having more than 3,000 members. All the webinar videos are available free for reference. Last time we had a webinar with Professor Paul Sugarbaker about HIPEC surgery, and you can see the participation here. Nearly 430 people participated. Today we are blessed with one of the pioneers in ERAS, none other than Professor Olle Ljungqvist. He is professor from Sweden. He is the chairman of ERA Society and chairman of European Nutrition for Health Alliance. And he will be formally introduced by Dr. Monish Karnagaran, and it will be moderated by Dr. Xavier George from Australia. Actually, George is joining us from Australia. It is on AM morning Monday. Thank you, George, for joining. Welcome, Professor Olle Ljungqvist and Professor George for joining Senadhipan Education Foundation. Dr. Monish Karnagaran, who is my colleague, will be introducing the speaker and moderator. Before that, I request all the participants to mute their mic on entry. If possible, kindly acknowledge by renaming your device by yours. Participants logging from outside India are requested to reveal their identity in the chat box. Raise your hand if you want to intervene. Everybody will be given permission to unmute their mic and discuss with the speaker directly. If you are on a portable device, please mute your audio and hide your video. Please contact us at senadhipan@gmail.com for any queries. I hand over the mic to Dr. Monish Karnagaran for introduction of the speaker and moderator.
Thank you, Baiju sir.
You can share your screen.
Yes. Is it visible now?
Yeah. Full screen.
Yes. Good evening, all delegates. Good afternoon, Professor Ljungqvist, and good morning, Professor Barretto. It's a great privilege for me to welcome you all to this forum. As much as all of us have been looking forward to it, the topic of today's discussion has pretty much revolutionized perioperative care in the past couple of decades. And to tell us how can we further enhance the perioperative experience of our patients, we have one of the greatest names in ERAS, Professor Olle Ljungqvist, with us today. Professor Ljungqvist received his medical degree and obtained his PhD in glucose metabolism and hemorrhage at Karolinska Institute, Sweden. He completed his residency and held several clinical positions in gastrointestinal surgery at Karolinska Hospital. In 2005, he was appointed Professor of Surgery, Nutrition and Metabolism at Karolinska Institute. He chaired the Center for Gastrointestinal Diseases at Ersta Hospital, Stockholm between 1999 to 2008, before taking up his current position as Professor of Surgery at OREBRO University, Sweden in 2009. Among his many contributions, Professor Ljungqvist co-founded ERA Society in 2010 and serves as its executive chairman. He served as a chair of European Society for Clinical Nutrition, ESPEN, the International Association for Surgical Metabolism and Nutrition, IASMEN, and he is currently chairing the European Nutrition for Health Alliance, ENHA. His research interests are surgical stress, metabolism, nutrition and outcomes, focusing on enhancing recovery after surgery. He proposed the use of preoperative carbohydrate loading instead of overnight fasting for elective surgery, which is now incorporated in the ERA Society guidelines and has been recommended worldwide. He has published more than 300 original articles, international guidelines, book chapters and reviews, and has co-edited several international textbooks on clinical nutrition and ERAS. He delivers about 20 international lectures a year. A warm welcome to you, Professor Ljungqvist. We're indeed thrilled to have you here. To moderate this session, we have another stalwart, Professor SAVIO George Barretto. Dr. Barretto is a gastrointestinal and HPV surgeon and academic, a researcher. He has trained and worked as a surgeon in India and Australia. He has obtained his PhD degree from Flinders University, Australia, for his work in acute pancreatitis. For more than a decade, he has been active in conducting research on pathophysiology, surgery, and outcomes of various diseases such as acute pancreatitis, pancreatic, gastric, and gallbladder cancers. He has authored more than 250 clinical and basic science research papers, as well as book chapters on various GI and HPV topics. He currently works as a consultant surgeon at Adelaide. He is a deputy director of medical program, Flinders University, and also coordinates advanced studies in the College of Medicine and Public Health, Flinders University, Adelaide, Australia. At a personal level, I have worked with Dr. Barretto both in clinical surgery as well as research, and I consider it a matter of tremendous fortune to have such a great teacher, a friend, and a mentor. Over to you, Dr. George.
Thank you, Dr. Monish. I welcome Dr. Olle Ljungqvist and Professor George Barretto once again to Senadhipan Education Foundation. We have almost 472 participants now itself. Over to George Barretto for proceedings.
Thank you, Professor Baiju, for this very kind invitation. And thank you, Manish, for your extremely kind and generous introduction. I think without much ado, we would all be waiting, and we're all waiting to hear from Professor Ljungqvist about the principles and practice of ERAS. Over to you, Prof.
Well, thank you very much. First of all, Dr. Senadhipan, for the invitation to join your worldwide educational system. I think that that's a privilege that is very dear to me. Thank you. And to Dr. Canagan for a very nice introduction. And it's a pleasure to be with you, Dr. Barretto, today as well. So I've been asked to give you an overview of the principles and the practice and a little bit of an update on ERAS, which of course is one of my favorite topics. I need to disclose that I did found the society. I'm also involved in a company that we initiated from the society, and I've been advising companies and so forth over the times. But let me just take you back a little bit in history, because for me, this all started when I met with Ken Fearon, who very sadly left us in 2016. Ken was a fantastic oncologic colorectal cancer surgeon and a researcher of world class in cancer cachexia. And we both had the ideas that we should try to do something about our colorectal cancer patients and try to have them recover quicker. He had been working with cancer cachexia, and I had done the preoperative carbohydrate work that was mentioned before. We were very much inspired by this man, Henrik Kellett, who had been driving something that he called fast track surgery. His background was from epidural anesthesia and pain management, but he proposed a multimodal approach to recovery. And this was a very, I think, groundbreaking piece of work, because he realized that you needed to do several things in combination in order to have the patients recover much quicker. And in fact, he had published data that where he had been able to have patients go home after open sigmoid resections in the mid-90s in 2 days at a time, when all the best centers in the world were having their patients in for 10 days or maybe even 2 weeks, which is still the case actually in many instances. And of course, people didn't believe this. They thought there was something strange about this, or something strange with Danish people, but in fact, it turned out to be true. So in 2001, Ken and I asked him and a couple of other colleagues and their groups to join us in what we called the Enhanced Recovery After Surgery Study Group. We didn't really like the wording fast track, because that sort of implied that it was just about getting the patients out fast. We wanted to focus on recovery and see how we could get patients to recover quicker. So what we did was we decided to take a very broad stand on the approach. We said, well, why don't we follow the idea that Henrik Kellett had, but widen it to look for everything and anything in the literature that would help us improve the outcomes of the patients, and just put that together to a perioperative guide. And this was published in 2005 in Clinical Nutrition, and has been a huge breakthrough for the whole concept of enhanced recovery. And what we found was that there was a number of things in the literature that actually could help us and lead the way. And this is a picture that I know many have used over the years to sort of have the patient's journey depicted this way, with different items that you should be doing according to the literature. Now, the thing was that when we looked at this array of treatments, we realized none of us were actually doing all of these things. So we decided that we would go ahead and try to practice this care that the literature suggested we should do. So we started to test it, and I'll tell you more about that in just a moment. But the philosophy behind the whole concept is as follows. First of all, we have to realize, what are we trying to achieve with recovery after surgery? Well, we want the patient back to preoperative function or better. And that implies that we need the gastrointestinals to function normally again, with normal food intake, and bowel movements should be back. Pain should be controlled on oral analgesics, and the patient should be mobile to the extent they were before the operation. And of course, we want to avoid complications. And if we achieve this, the patient is ready to go home. So very clear clinical outcomes that we were looking for. But if we want to approach this, we need to understand the pathophysiology behind some of the key problems that we were actually facing postoperatively. Postoperative ileus is one of those things that I think that every surgeon around the world has experienced, probably one of the most common complications. If we go through the literature and what is available about knowledge here, it is clear that there's a number of different things that can cause postoperative ileus. It is because of the somatic and visceral trauma that we're inflicting, the gut handling and the anastomosis, but also other things. Fluids play a very important part here, and which choices of analgesia that we're deciding to use. Now, all of these issues here have different ways and cause different reactions in the body that all can end up in nausea, vomiting, distension, or absolute constipation. Realizing this, it is not so strange that a multimodal problem needs a multimodal care approach. And if you go through this specific one, you can see that if you go through the literature as this group around Dilip Lobo did some years ago, there's a whole range of different things that will have more or less effective impact on the postoperative ileus. So clearly, you need to have this kind of approach, and that is behind the physiology or the philosophy of how we're moving ahead. So what is it then that makes ERAS work? Well, let's talk a little bit about the pathophysiology, because surgery is a stressor. Causes the release of stress hormones from the injury site. We have these activations of nerve impulses and humoral agents that cause the release of hormones and cytokines that have massive impact on muscle metabolism, glucose metabolism, the whole body metabolism. But the bottom line of and what is important for us is the whole body protein catabolism and the development of insulin resistance, which will cause hyperglycemia as the most pronounced clinical sign that we can have. But that actually has a lot of other implications as well. But with this at hand, it is important that when we are in a state of insulin resistance, not only is the body breaking down muscle protein, which will have a range of different effects, but even if we're trying to feed the patient, metabolism is set in such a way that the body is not able to manage the nutrients, because in a way we are like untreated diabetics in this situation. Now, if we are going to treat this kind of pretty major issue when it comes to changes in body metabolism, and realizing that we have a number of different things that can be done or should be done, we need to have an integrated approach to the ERAS care program that we have. So it involves surgical items, anesthesia, and not least nursing. Nursing is going to be driving a lot of these things. So very, very important part of what we're talking about here. And we have to start even before the patient comes to the hospital, from the pre-admission situation, and then have a smooth flow of different treatments all the way through the preoperative, intraoperative, and postoperative phases. Now, this is really the key to making all of this work. And it's about having everybody understanding what their specific role is as the patient is passing by their station in the care pathway. So let me just give you one example of how these different elements that were actually found in the literature, which is now in the guidelines, how that affects insulin sensitivity, because that's a pretty good marker of how the body is reacting. With normal insulin sensitivity, we feel absolutely fine. There's no sign of any diabetes. The body can be anabolic, etc. But with insulin resistance, the body is going to be catabolic, okay? So in a traditional open surgical situation, we would typically have bowel preparation and certainly no nutrition, overnight fasting, preoperative sedation, and so forth in the preoperative phase. As opposed to that, what we found in the literature was that it's much better to have the patient to eat normal dinner, avoid that bowel prep, give a carbohydrate treatment that actually elevates the insulin sensitivity before the onset of the operation. On top of that, if this is an open operation, you can block the release of stress hormones with a thoracic epidural, which will render the patient much less steep in their drop in insulin sensitivity as compared to if that is not activated before and not in place before the operation. In the postoperative phase, the literature tells us we should start to feed the patient and mobilize them as much as possible. And that will have them back on track upwards instead of the low caloric IV fluids and nothing per os that was the traditional care. And of course, it's going to take much longer to get back to normal if you're all the way down here. So that can give you sort of a view of how these elements, many of them actually impact the stress response, which impact the way that the body is able to manage and behave. So with that at hand, now we understand a little bit about why ERAS is working or how it is working and the approach that we had from the beginning. And in fact, starting with colorectal, we've now broadened that to just about every major operation that is available. But you may also ask yourself, so what is this all about? Why is it getting so much attention? Well, we need to look at some of the data. And again, I'm going to take you back in history a little bit because our Dutch friends had the opportunity to train hospitals in a very structured way using our guideline, the one that I just showed you before. And what they found was that with structured implementation, they were able to reduce the length of stay of these open colonic resections from about 9 to 10 days down to 5 and 6 days. And what was behind that change was an improvement in compliance and adherence to our guidelines from 44% to 75%. So it seemed like if you were following these guidelines, you would also get better results. And around the same time, we also put together a meta-analysis from the randomized trials that were available at that time. And that showed us that ERAS, using more of the ERAS elements as opposed to fewer, you can expect to have a marked reduction in complications, down by around 50%. So those two things was really essential in the development of ERAS. And they both were made available or made apparent around 2010. So it took almost 10 years to get to there. Another thing that has really popularized ERAS a lot is that because of the reduction in length of stay, freeing up hospital beds, and much better use of available resources, and also not least the reduction in complications, this is going to save healthcare providers a lot of money. So here's just one example that I was involved in writing a review on how cost savings can be achieved with ERAS. And there are numerous of these reports around the world showing the same gains or savings when you start to employ these types of principles. We also did another study back in time that was published in 2011 that I think really has a lot of importance. And that showed us that as we were starting to put ERAS in place, we did have some opposition amongst our colleagues in anesthesia, but also some surgeons were a little bit slower than others. And we were recording the change over time and looked at compliance and outcomes. And what we found when we put together this data of about 1,000 consecutive open colorectal cancer patients was that with better compliance, there was a gradual increase or decrease in complications. And this has since then been shown to be very true. And I'll come back to that later because others have actually proven the same thing. We went on from this single institution report to a multinational study with 13 hospitals in 7 countries, this time more than 2,300 patients, and again, exactly the same trend for overall complications. But this time we also had enough data to show a significant reduction in major complications, which again has, I think, stronger implications. We later then went on to look at the follow-up of our own data, the slide that I just showed you before, the 1,000 patients, and we found that there was a difference in survival with the patients that had been with better compliance, fewer complications, also had a much better outcome when it came to 5-year survival compared to those with below 70% of compliance. Now, this was in open surgery, but incidentally, a couple of years later, this Polish group completely independently published the same kind of data in laparoscopic surgery, but a 3-year follow-up. But again, associated with higher compliance, this time the cutoff was 80%. They had fewer complications, faster return of functions, and shorter stay, but also an impact on survival. How could that possibly be so? Well, there are a lot of different ideas around that, but I think this is maybe one of the more plausible ones. It is that a lot of issues around the surgery, especially the stressors, will impact residual tumor cells that may not be removed. And here you can see in particular where certainly affecting the stress hormones or the stress responses, but also the choice of analgesia, and on top of that, the immune functions. So there are hypotheses and ideas around how that actually could make sense. Now I'd like to shift gears a little bit by talking about the ERA Society and what we're doing, because around 2010, we had the data showing that we could, using our guidelines and the methodology to put together a guideline, actually could make a big difference in the outcomes of patients. We also knew that there were ways to help people implement these ideas and work a little bit differently to get very good results in a very short period of time. The training that the Dutch had done lasted about 8 to 10 months. So in a very fast fast-running program, tremendous results could be gained, actually. So we decided that we would form a multi-professional, multidisciplinary medical society, completely non-profit organization, of course, and the mission was to enhance recovery after surgery. And we wanted to develop perioperative care and improve the recovery of patients. So we would be doing research and education, but we also wanted to help people implement evidence-based practice. And we knew that one of the keys to do that was to audit the details of what was going on in your own unit. Because early on, what we had found was that we looked at the guideline that we had put together. We started to collect data on how well we were following these guidelines. We thought we had a pretty good idea of where our problems might be. But when we looked at the processes of the guidelines and the process of care that we were actually delivering, we realized that we had been very wrong about what was going on in our own institutions. We had problems where we definitely thought things were working well and vice versa. So clearly, there was no way we were going to be able to run a proper implementation program if we were aiming at the wrong things. You have to know what's going on in detail in order to be able to raise your compliance and get those improvements in your results. So we started in 2010 with a few leading academic centers to form the society. We have since then been growing into regional networks, Canada, USA, Latin America, Africa, Asia, and the main society mainly in Europe, but also as a mother society linked to all the other ones. And the way that we've done this is we have been training hospitals ourselves from the core of the ERA Society regionally. with the ERS implementation program that I'll mention in just a moment. And then from the best units, we have trained trainers and developed centers of excellence that are available to train others in that region. And once the hospitals have been trained, they become what we call a qualified ERS qualified hospital. And they were able then to spread to other disciplines within that hospital, but also be part of a large networking community. So this is how we've been spreading the word, trying to actually help people implement best practice. So today we have about 250 units in more than 25 countries. I believe it's 28 countries right now. And it was very nice to see that when Newsweek presented the world's 15 best hospitals last year, we had a lot of those hospitals in the top 15 list were hospitals working with us. So we've been very happy to have excellent people working with us around the world. Now, of course, you're probably aware that we have been developing guidelines in a lot of different domains, and we've been extremely fortunate to have some of the very most talented people join us in different ways to help us find out what is the best available evidence for the care in different specialties. And we've been developing the ways that we do these guidelines also over time, and I think we're getting better and better at doing it. Just over the last year, we've published the first part of the emergency laparotomy. AAA open surgery is coming very soon, and some other ones are on their way, as well as some updates of some older guidelines. What is important is that they're all available for you to download free through the ERS website that's given here. Now, we realized that they have been getting a lot of attention, and when we did a review for JAMA surgery last year, we checked on this and found that there were more than 6,000 citations at that time and more than 700,000 downloads. So we take this very seriously. We try to do our best to actually produce something that is worthwhile looking at. And we've been, like I said, very fortunate to have good people working with us. Now, so we've been around we started 20 years ago, and the society's been around more than 10 years now. And everybody knows about ERS, and we've been talking about ERS a long time, and it's been around. Do we really need it? Well, I think one way to answer that question is to do a little bit of a reality check on surgery. So just before COVID-19 hit us, the situation was pretty much like this, that 5% of the population was operated in the Western world, slightly less in other parts of the world, but roughly the World Health Organizations were estimating more than 300 million operations every year. And out of those, 25% would get a complication. Now, the reason for that is clear to me, and I think it will be clear to you as well very soon. Best practice is not in use. That's why we have this problem. And it takes a very long time to change practice. And I'll give you a few examples. Because of this, because of the slowness in changing, we have a huge variation in how care is delivered. And this is why we have the differences in outcomes as well. And of course, now we have COVID-19. I'll come back to that in just a moment. Let's reflect a little bit about variations in outcomes. And I'm just going to give you a very, very quick overview of some data that I think might be interesting. Here's a study. It's getting a little bit old, but it really hasn't changed all that much. This is all the different countries in Europe. They looked at the risk of dying after major abdominal surgery in the different countries. And what you're seeing here is a logarithmic scale on that difference in different countries. Now, Europe is supposed to have the best care in the world. It's the most developed part of the world, the richest part of the world, you name it. And still, this is the kind of variation that you're seeing. And I think that that's a pretty obvious picture. If we go to a single country, I picked my own, because in Sweden, everybody thinks they're getting the same care everywhere. So here is from our own national quality registry, which everybody has to fill in. This is all the colonic cancer surgeries in 2019, I believe it is. And here we see the risk of a complication in one hospital compared to another. It ranges from 38% to 13%. So a threefold difference. And the national average is 25%. So what's behind that kind of numbers? Well, here we have from the same year in blue that all the different hospitals using open surgery. The yellow are the cases done in laparoscopic surgery, and the gray are the converted ones. Started laparoscopic, then changed to open. And you can see surgical technique is very different in the different hospitals. And here you can see how slow we have been in the different regions in Sweden to adopt minimal invasive surgery as an example of the very slow development that we're facing in surgery. Here's another slide that also tells us something. This is now anesthesia. Of course, they can also impact outcomes. So here's just an example of the variation depending on the anesthesiologist himself or herself. Here's a 1 hour uncomplicated open laparotomy. And you see the variation in how much fluid was given to the patients. It varies by 20-fold. And of course, too much fluid is going to drown the patient, and too little fluid is going to keep the patient too dry. So here is another example. So it is the variation in outcomes that is a result from the variation in care delivery. So what can we do about this? Well, we know that when we minimize the variation in care delivery and have more of the elements that have been proven to improve outcomes put in place, we get shorter hospital stay. We bring it down from weeks to days. The reduction in complications is down between 30 and 50%, most surgeries. Of course, we're saving cost. And we've shown several examples now of improved survival. I just showed you two pieces of data. There's much more out there. And the other thing, which is nice, we've shown around the world that it actually works. It works everywhere. It doesn't matter which system you have or what your situation is. We've improved the outcome of Mayo Clinic, but also of units that are in very, very poor circumstances in Latin America or Africa, for example. So what's the challenge today? Well, I almost touched on it before because everybody knows about ERS or think they do. And a lot of people, in fact, it's a very long time ago since I heard anybody say that they were not doing ERAS in some sort of way or fast track, and probably said they've done it for years. But if I ask them if they have some data to show on their compliance or their outcomes, usually there is nothing. And if we go to the data that is available, and here are some examples, we have from France, National Registry, Germany, and actually there's the same in Canada and other places in Japan. The length of stay average is above 10 days for something that should be around 5 if everybody was actually doing enhanced recovery, or even lower for some of them. Even in the US, where the main hospitals are in this system, the data is too high for being correct. So when I say that somebody's doing the ERAS according to my look at it, it is according to the guideline. And that means that they have full control over how well they're following guidelines. And they know not only the outcomes, but also the processes. And I think this is something that the surgical world is really missing. We don't even have data on the main outcomes. If you go to the Lancet Commission on Global Surgery a few years ago, there was only 29 countries in the world that could give mortality data in surgery. Only 20, the rest could not. I'll give you another example. Gynecologic Oncology, a publication from a couple of years ago. Worldwide distribution of responders, 37% reported they had implemented ERAS, different in different parts of the world, as you can see. But if you then checked what they were actually doing, well, more than 80% compliance was there for a few of the elements, such as DVT prophylaxis, urinary catheters, and so forth, but very poor compliance according to a lot of the other elements that are key to the outcomes of ERAS. So really, people think they're doing something because they picked and choose a few things, but overall they haven't. And this impacts the outcome, because if you look at, if you're following the guidelines, here are the number of elements in place for low complexity surgery, minor surgery. Even there you can see a clear improvement in length of stay with better compliance. But if you go to the more complex surgery, the major surgeries, a huge difference in length of stay and outcomes. So clearly it works for gynae as well. Now I'm going to take you to another set of data from a study from Spain, where they had national training of many hospitals with lectures, protocols, and reports. So a good, forceful way of trying to improve outcomes. And they trained a number of hospitals, but they also looked at hospitals that had not been trained. And they reported significantly better outcomes with compliance between the trained hospitals, 73% versus 64% in the non-trained. But if you look at the variation among the groups, they were almost completely overlapping. Still, the ERAS centers had better outcomes with fewer complications. 23% is not bad, mainly because of infections, and length of stay was down 1 day. Now, the authors did something very clever with this data. They divided the entire data set into quartiles, depending on how well they were complying. The high compliers were about 78% or higher, and the low compliant group quartile was 54% and lower. And now you compare those two and you see a huge difference in outcomes. 66% fewer complications, half the leaks, arrhythmias, infections, ileus, and UTIs in the 70s and 80s, and length of stay down 3 days. They also did a linear fit with the entire population. And here you can see basically all the complications that we're trying to avoid were fewer with better compliance. So what is then the missing point? Why are some hospitals not doing better than others, even if they have training? And my answer to you would be audit. Because if you look at the data again from the Spanish group, they looked at which elements made a difference in their data set. And you can see here's almost the entire list of the ERAS guidelines. So this is a typical example of where each and every one of the elements actually do make a small but still significant difference. And that's why it is best to keep track of all of these elements as best as you can. So it's not that the care that you believe is being delivered, it is knowing that you deliver the right care. That's the secret. So that's something that we have taken on board and that we learned many years ago, and now that we've refined over almost 20 years. So what we're doing now, we have a structured implementation program with a team of people. I'll come back to that in just a moment, with seminars with a very structured content where we train people to use data, to collect data, analyze data, and make changes according to data. And they train and they do a lot of homework in between, during which time we also coach them very carefully and very closely, because every hospital is different and they need their own specific coaching for their issues. At the core of every hospital is a team of a surgeon, anesthesiologist, and a coordinating nurse. And they, because it may seem like a long time, 8 to 10 months, but in fact, they start to use ERAS already after 2 to 3 months. The rest is mainly fine-tuning. So to support this, we have developed the ERAS interactive audit system. It is an implementation tool to help units get full control. It is also a quality registry because you can update, you get updated results, you benchmark, and we use it for research. Many publications already in place from this tool, and we use it for updating with new guidelines. And basically, I'm going to show you a few slides how this works. You enter data, you analyze and you share, and you look at the different elements, how well you're complying. I'll give you an example. Here's the patient's journey through the operation with different pages. You fill in data as you move along. You have help text with definitions so that everybody knows what they're supposed to do and what certain things mean. It takes about 20 to 30 minutes to do this manually, but with the new system that is available also, you can have developed an automatic transfer of data. That's something that's being developed now. But basically what you get is a report section which contains where you can do analysis. So here's your length of stay, your compliance over time. You can see it jumped here. That's when the training took place. And then you have the primary complications, but also the types of surgeries that were done. So here's a typical example of what we found in 2010 when we started to use this. Here's a hospital where some things are working in blue, some elements as are listed here, the care elements, some are not in place at all, and some are just used a little bit to some extent. So they can focus on the right things, and then after training, it may look something like this. And what you're finding is actually that things are improving. Now, the other thing that the system can be used for is to understand why do we have certain problems and what can we do about that. So here's, again, postoperative nausea and vomiting, very common problem. You just click on that bar and then you get you can go and get the patients that had this problem, and you can then start to discuss among yourselves which are the elements that actually could make a difference here. Well, these patients didn't get education, they didn't carbohydrate loading, many were given long-term sedation, PONV was missed, and there are a number of things here with fluids, no gut stimulation, etc. And so you can see a whole range of different things that actually helped cause this problem in these patients. And then you may think, well, that's very complicated because here we have the patient's journey through clinic, pre-op, and so forth. And the blue ones are the ones that have with surgery to do, so surgical decisions. The red ones that also had an issue with this are in the hands of anesthesia. So how do we drive this? We need to change a lot of different things. Well, again, you can have useful data assembled because each one of the element, you can go to the clinic and show them, well, the preoperative carbohydrates was not given at all. And then you can feedback as they change their practice, and you can then have them really feel proud about having been able to make the change. Here's another one where anesthesia was successful initially, but then jumped up and down. And here's one where it was much more difficult. And here's one that started to fail. So again, but by making this public to everybody involved, not just your own data, but everybody's data, you can actually create the spirit to drive change in a very productive way. And let me just go back to this study again, because this is another mistake that other people do. The mistake was not this program, but it was a mistake to make it only a program. Because what happened was they finished this program. And when you finish a program, the risk is that you're going to be falling back. And that's exactly what happened with these teams. They had 35 teams initially. Our friends in Holland went back and looked at the 10 most successful hospitals a few years after the program had finished. And here you can see that most of those hospitals actually fell back in overall adherence. And with that, they had superb effect of their training during the implementation, but after the implementation falling back, they had also been getting much less or longer length of stay, despite the fact that they had moved from open to laparoscopic surgery. In contrast to that, here's a team that has been working several years with keeping track of their data. And you can see how compliance is going up gradually over time as length of stay is coming down. And that's a typical example of a well-functioning ERS team. I'm going to finish off by a few words on ERS in the pandemic. And here's just some data from last month, late last month. The spread of COVID is all over the world. We know that. And it comes in waves that we've been talking about and we've been seeing. You have been, I think, reasonably saved from it when you compare to the European side. At least now you can see here, really shooting away over here. We also know that vaccination helps, and that was obvious well, with the early experiences, and I picked this one because it was the first big study from Israel showing that hospitalization, ICU care, and mortality were all dropped down and basically stopped when they got vaccination in place compared to those unvaccinated in red. And the booster dose is also affected. We've known that from late last year. So that's another one. But the problem is, and this may be something affecting many of our listeners, is that the vaccination globally is unevenly distributed. And that has opened up for new variants such as the Omicron, which is hitting us over here very strongly. And I understand the same is in Australia. So it keeps coming back, and restrictions are also coming back, and we all recognize them too well. So the message is that this is far from over. I think this will keep the pressure up for some time. Some glimmer of hope if you look at South Africa, where things have cooled down a lot. Maybe Omicron is going to kill the whole pandemic by itself. Let's hope for that. But it has had a lot of effects on surgery. We have been reorganizing hospitals, shut down operating rooms, developed ICU beds, deployed surgical beds for COVID, and relocated surgical staff. And this has led to a fast-growing queue of patients, and I understand that that's the same in at least parts of India today. Certainly over here in Europe, and this is just a report from the Royal College of Surgeons of England this summer, and they estimated at that time 5 million waiting and more than 400,000 more than a year. And they were predicting that this would grow even more. And they needed to double hospital beds and get more doctors in place, which is going to be very, very tough. So I think we're facing a tough situation in the aftermath as well, not least because this is going to be very costly. The insurance companies, if you look at the US, they are demanding cost sharing for COVID-19. This is unheard of, but now they're really starting to push. It's too costly for them. And that is going to be, makes it very obvious, but even if you have state-run healthcare, the cost is going to be high. And that's going to put additional pressure on us delivering care. So how can ERAS then be part of the solution at least? Well, we can shorten the hospital bed, the hospital stay to free up beds. Same thing with complications, free up ICU beds, and we can save resources, and we know that it works. So I'd just like to by letting you know a little bit more about the ERAS Society, I'd like to have all of you come and join us. Just go to our website and you can find what's there. One of the things that is really good as a member is that you get a really good rebate when you, if you want to buy our textbook, which really covers everything you want to know about ERAS, or if you want to come and join us, we're hoping to hold this World Congress finally again, 1st and 3rd of June of next year. So concluding, why ERAS today? Well, we can deliver faster recovery, fewer complications, and lower cost. It is a new way of working, and it is working through minimization of the stress of surgery. We can help deal with the backlog of surgery. And what is good is that with the pressure that COVID put on all of us in surgery and anesthesia, we showed that all of us involved in surgical care can actually change, which has been the biggest barrier to improvement of care in the past. So I'll leave you with this. I think that ERAS is needed more than ever. Thank you so much for the opportunity to speak to you today, and I'd be happy to take on any discussion.
Thank you, Professor Olle Ljungqvist, for the wonderful talk. Actually, we really enjoyed your talk. Actually, we had reached the maximum capacity of the Zoom, actually 500 people logged in. We tried to increase the capacity, but unfortunately, we couldn't do it. We had more than 500 members, delegates here.
Fantastic.
Thank you, Professor, once again for joining. I requested Dr.  ジョージ BARRETTO to continue the discussion.
Thank you very much, Professor Ljungqvist, for this fantastic talk. What I will do at the start is I'm just going to summarize some of Professor Ljungqvist's key points, and then I will address the questions, or I will pose the questions from the audience in the chat to Professor Ljungqvist. So, I mean, on behalf of the global clinical fraternity, I really wish to thank you, Prof, and the ERAS Society for revolutionizing perioperative patient care. I mean, what you all have done is the ideal way, a systematic approach, not just proposing guidelines, but auditing the work you've done. And you are continuing that fantastic work by training healthcare workers. Now, Professor Ljungqvist highlighted a very, very important point. There's global variation in surgery and perioperative care. And he stressed the importance of ERAS as a means to minimizing variation. In Australia, we have a very famous adage. It's called know the plan, share the plan. And what he's basically telling us is that the team works together towards a plan. The key is the team, with everyone understanding their role. Now, from a physiological or pathophysiological standpoint, Prof raised a very important issue of insulin resistance, and not just in diabetics. And this is something that we have to understand as a stress response in surgery. The next point he spoke about was, for success, the focus must be on compliance. And it's very important to audit one's program, whether it's a clinical pathway or ERAS, the full shebang. It's very important to audit it in order to, because if we can improve compliance, that's the only way we can get the intended results. Now, with that, I will ask Prof one question, and that was with regard to the 5-year survival and 3-year survival data that you showed us. And it was quite clear that compliance is related to those improved survival. So does that mean that patients who have better stages in cancer or better diseases are more prone to have a better compliance rate, and that's why they had a better survival? I'm just playing the devil's advocate.
No, that's fine. That's a very good question, obviously. No, the answer to that, we controlled for all of those factors in our paper. And if I'm not mistaken, I think the Polish group did the same. I just showed those two because those are within my domain, and it's pretty big studies. There is another very interesting study, because this is going to be almost impossible to do a randomized trial on. But there is something that could be looked upon as close as you can get. And it's from a colleague in Bangkok. What he did, he was in England for several years and trained in enhanced recovery. He came back to his mother hospital in Bangkok, and he started to practice this while all his other colleagues continued to do care in the traditional way. But they all agreed to capture care processes according to ERAS and outcomes. And what he reported was exactly the same data. So his patients, same type of patients, there was no difference in the types of patients, and they obviously came to this group, and characteristics and all these things were the same, but the outcomes were hugely different, actually. So I think it has to do with the fact that, and another piece of information that is out there is also the big data from NSQIP. I'm sure you're aware of that. It followed 100,000 patients over 10 years, and they reported that with a higher complication risk. Also, you did shorter survival. So I think there's something to that. Actually, having a complication is not just dangerous in the short term, but seems to be associated also with long term. But of course, like I said, we're never going to be able to prove it with the highest level of evidence, but the association coming back over and over again is intriguing. What's your view on it?
Yeah, I mean, I am concerned, or I have been a bit concerned that, because we looked at our own data with our clinical pathways and compliance. And in fact, Monish was the one who did the study, and this was in pancreatic surgical patients. And there appeared, I mean, the numbers are very small in terms of the complications to give us a clear idea whether there was more, if it was, compliance issue was more with those who had a worse off disease in total. But it appeared that way. And
yeah, go ahead. Sorry, I just remembered something. Go ahead. No,
you go. I don't want to stop your train of thought.
No, it's just it's very important that you look at the right compliance elements. If you start to involve the postoperative compliance elements as part of what you're looking at, then I think you may be fooling yourself a little bit. So it's about looking at the pre and intraoperative compliance elements, which are really the ones that we control. The postoperative, if the patient is mobilizing, if they're up and eating, if, those things are very much an effect of how well you did the preoperative ones, and actually may be a much better sign of if the patient is on their way to recover or not, or if they're on their way to develop a complication. So you got to be careful with what you're actually using as your compliant element. Yeah.
Absolutely. So, Prof, I'm now going to pose some of the questions that have been raised by people in the audience. There's Professor Inian Samarasam from CMC Vellore, and his question was with regards to compliance. He says a key element is patient understanding, patient education, and engagement. So how do we ensure and support compliance in those situations?
This is another very good question, and I think one of the key aspects of the process, because it's about getting engagement from the patient as well. So the way that we have been approaching this and what we've developed is, that we want to make sure that we give the information at a time when the patient is as little stressed as possible. So it's picking the right time, and we usually do that separately from the time when there has been a decision that the patient is going to be operated, or that you've mentioned they may have cancer. Once you've said any of those things, many people just are not hearing anything after that. So separate from that. Secondly, we give them oral and written and sometimes visual information of what's going to be happening. We give them a sort of a diary that they can follow themselves, and in many hospitals like to use that diary to actually really engage the patient and in performing their parts of what they can do in order to get better postoperative compliance. The other thing is to make sure that the patient is not alone when they get the information. So you should have a caregiver, a relative, somebody else there also listening in. And there's a very simple method that you can actually test whether the patient has understood what you've been talking about. And I believe it's called in English talkback method. So you just ask the patient to tell you what they're going to tell their son or daughter, somebody who was not in the room, about what's going to happen. And then you will get a good feel if they have understood what this is all about or not.
The next question was from Dr. Aradhna, and her question was, what are the examples of carbohydrates that can be used before surgery? And I understand where she's coming from. This is India, where we do not always have ready-made preparations.
Yes, I understand that. This is well, a carbohydrate drink can be made in so many different ways. So it's virtually, and they will have completely different effects in the body. So a preoperative carbohydrate drink is really a drink that will have enough carbohydrates at a concentration that will elicit an insulin release that we see after a normal meal. That's the whole point of the drink. And then it has to be safe. So that means that the carbohydrates should be combined. It should be maltodextrins primarily, because that brings down the osmolality, which will allow it to pass the stomach quicker and therefore avoid the risk of any aspiration. So what has been developed commercially available is a 12.5% carbohydrate, which has been proven to be about right. And that keeps an osmolality of is slightly hypoosmolar. And that has been shown to give that response in insulin. So the problem is that people start using Gatorade or sports drinks, which have a completely different target and should have a different way of functioning as well. And that they will not give that insulin release because you don't want that if you're in sports. If it's not available, I would talk to your pharmacy perhaps and see if they could mix something, or speak to representatives. So there are now several companies out there with the right type of formulation. I believe there's Nutricia was first, and then there's Nestle has something. I believe Abbott has something as well, but there are also a couple of other companies that are just sort of riding on the data of that formulation, whereas their own formulation is different. And so I would ask anybody trying to sell a carbohydrate drink for their data on their specific product, so you don't get fooled there. Yeah, I know there are people who have tried also to find different juices and so forth, but again, you know, you don't know for sure if it's working or not.
The next question is from Kshitij Gupta, and his question was, how do we reduce complications in high-risk patients, and more importantly, how do we apply ERAS to high-risk patients?
This is a very, very common and good question. The thing is that if we look at, if you remember the list of complications that were reduced in particular in the Spanish study, which is a big study, you will find that it was the typical organs that causes problems. Well, infections for sure, but also cardiac problems, pulmonary problems, etc. So what we're doing with ERAS is we're protecting the vulnerable organs from more stress. That means that in the compromised patient that comes into surgery with this problem, they are the ones that actually gain the most from getting ERAS. So, but I remember when we started this, one of the main crucial issues that we needed to handle was anesthesia saying, you can't do this on this patient, it's too fragile. But it's actually completely the other way around. Of course, some patients may need to have certain things not given to them. If you're an unstable diabetic, you should give the carbohydrates, for example. But overall, in general, this is the best thing you can do for your fragile, vulnerable patients.
Which brings me to the next question from Dr. Sagar HC. His question was, does ERAS reduce surgical or non-surgical complications?
Actually, mainly non-surgical complications is what usually is showing up, but there are in greater data and in some different surgeries, there seems to be some effect on surgical complications as well. But it's not as prominent, which again fits very well with the whole idea. I think it's indirect more. I mean, fewer leaks have been reported in some large studies for colorectal, but I think that might be an effect of fluid management or you know, things like that, or cardiovascular management.
Okay. Now the next question, Prof, I'm not sure whether you would be able to give us an answer. It's from Dr. Anjali Davle, and her question is, what changes need to be made in endotracheal intubation and drugs, anesthetic drugs, and gases used?
Okay, again, that is not my specialty. I don't think you need to change anything in particular when it comes to intubation, because I mean, if you're worried about the patient has had something to drink 2 hours before, you needn't worry about that. So I think a straightforward intubation could be the normal way. I know that for lung surgery, there might be some issues about, you know, how the ventilation, but that would be, I'm not the right person to answer that. When it comes to drugs, I think a couple of things are really important. Long-acting sedation given before patients who are worried should be avoided. If you want to give any kind of soothing medication, it should be short-acting before the operation. Secondly, long-acting opioids should be avoided because that causes a lot of different problems post-operatively. When it comes to the gases, I think that, well, again, not my specialty, but I think modern gases are probably what people are recommending today. But I think part of what is probably most important is that, another thing which is good is fast-acting anesthesia overall is good to have the patient awake quicker after the operation. And the other thing that is very important for anesthesiologists keep track of is fluid management. It's very easy to give too much fluid, and it's much better to give a combination of fluids and vasopressors to keep hemodynamics in place.
So thank you, Prof, because that probably answers the question by Dr. Ananta, who asked you to enlighten us on fluid management and whether goal-directed therapy would be the way to go.
Yeah, well, goal-directed fluid therapy, I think is very useful in certain patients. And at the moment, the recommendation is to use this for high-risk patients, but perhaps not in the ordinary sort of well-feeling patient. It seems like an overkill. What we're finding with fluid balance, a very simple way actually, is to just weigh the patient before and after, and then target your fluids so that you end up with close to zero change in body weight. And that means that you could gain maybe 1 or 2 kilos, but not more than that. We certainly try to get rid of fluids very quickly after the operation, and then instead have the patient to drink. Yeah.
And Dr. Miguel asks the question whether you would recommend ERAS in hernia surgery as well.
Well, it depends on which hernia you're talking about. A small inguinal hernia done in maybe in local anesthetics, or very minimal invasive kind of approach.
I think he was, because his next question a little further talks about laparoscopic surgery and intraperitoneal anesthesia in the cavity. So I think he's talking laparoscopic hernia repairs.
Okay, yeah, okay. Well, we don't have a protocol for that yet. We just haven't been. Well, no, it's not developed yet. So, but the general principles of looking into the evidence in the literature and find out what is working and employ that should work for any surgery. We started with bigger operations because that's where you have the biggest impact, obviously. But it's trickling down. We now have even an update on bariatric laparoscopic surgery.
Excellent. The next question from Jagdeep Sharma, whose question is about extended thromboprophylaxis. He says it's strongly recommended, but the issue is giving it for 28 days. And what would be a more practical approach to ensure an adequate duration?
Yeah, this is, if you go to the literature today, the data would support a prolonged, for cancer surgery, for a prolonged prophylaxis. But if you check with what people are doing, and I know even ERAS centers, in particular in Europe, I would say, they, with the patients now out of bed, moving around, I know that some people are practicing in-hospital use of this kind of prophylaxis and then drop it, actually. But again, we follow the principles of what's the data. We follow the data, and what we're lacking is a proper big trial to prove that it's equally safe, or before we are going to change that recommendation. I know it's cumbersome. It is very difficult. Let's put it this way: the recommendation would be at least in hospital stay while in hospital. I think that's the only thing I can say. But it's, we're giving recommendations, and then of course local circumstances may, impact the decision that you just have to make. Maybe it's not even available.
Dr. Selvaraj's question is there a role of diuretics in ERAS?
Well, we don't give it routinely. We are not too worried about stress-induced oliguria. There's good data actually from New Zealand. Matthias Soup published some data where he randomized, treating lower versus more normal urine production, and there's very little to show that there should be any risk in normal patients. It's the one that have a kidney problem before going into surgery that you may need to keep a much closer track on that.
The next question is from Dr. Tushar Mishra, and you partially answered this question, Prof. He asks, how is oral maltodextrin better than oral glucose or starch in the preoperative carbohydrate loading?
Okay, if you're going to give a 12% glucose solution, that's going to be a very high osmolality, and that carries the risk of emptying the stomach very slowly. So that could actually impose a risk of aspiration. Would not recommend that anytime. You need to bring that osmolality down in the beverage that you're planning to give. Otherwise, I cannot guarantee any safety, and I would be very cautious. And in fact, if you put something together on your own, I would be careful to test it, if possible, before you start to use it.
All right. Thank you, Prof. The next question from Dr. Vinod Parashar. And Dr. Parashar's question is, if patients are on prophylaxis for DVT, would you still advise epidural analgesia or any other alternate pain method?
Well, as far as I understand the anesthesiologist expertise on this is that if you have, well, it depends on which kind of prophylaxis they have to begin with. But if you're talking about low molecular heparin, for example, or if it's longer acting, then you would have to remove that before you go into surgery. But if it's a short acting one, I think there's a time limit of you should take it out at least 12 hours before you give the epidural. But once you put the epidural in, I think it's a couple of hours after it's been in place, or you've been giving a spinal, for example, 2 hours, I think you can give that. But if you have a catheter in, I think maybe you should wait a little bit longer. I'm sorry, I don't remember exactly all those details, but I think it should be in the guidelines. So I would recommend you to take a look there.
Yeah. The only thing I can add is they would not, the anesthetist would not want you to give the dose on the morning when they're going to take the catheter out. They would much
exactly, same thing.
Yeah.
Same thing. You need that time span.
Yeah.
Yeah, before you manipulate in the back.
The next question, Prof, is from Dr. Emmanuel, whose question is the ERAS Society thinking about developing guidelines for ERAS in relation to abdominal wall reconstruction?
Yes, that is actually one of the things that we have initiated some discussions with people involved in hernia societies to do that, because that would be I think that would be very meaningful. I think we can do some good there.
Okay.
I can't give you any timelines, though. I'm sorry. It varies so much.
Thank you, Prof. Dr. Madhabananda, the question is, are you aware of any differences in outcomes at ERAS in patients who have long-term diabetes?
I am not aware of any such data, to be frank. No, I haven't seen any particular study that I can think of off the top of my head. Well, except, yes, now I remember one study that's in hip and knee, actually from Denmark, where they have a big population study that they followed several thousand patients, and they showed that it was Kellett's fast track program, which is in essence pretty much the same. They showed that these patients, many of these patients needed more additional medication, and so they were actually doing very well with this kind of program, which again makes perfect sense, because they would, they would also benefit from the reduced stress, certainly.
The next question, thank you, Prof. The next question by Dr. Santosh has already been answered. It's regards in relation to the long-term oncological outcomes. The next question, there is no name, but the question is, do you advocate meditation, yoga, or brisk walking as part of ERAS? And what is the ideal period to start implementing ERAS? Preoperatively.
Yeah, to get back and yes, well, I mean, we have this, there's the data from prehabilitation, which is probably the closest data to the question being asked. And I think that there are several promising studies on prehabilitation, which contains then 3 components in its original form by Carly. And it is physical training. It is additional proteins that were taken in association with, in conjunction with that training, but it's also mental preparation. So those 3 components prepare the patient before the operation. And I think they haven't been showing a reduction yet that is convincing when it comes to complications, but there's certainly studies moving in this direction, and that patients in general are recovering a little bit quicker. They have better mobility post-operatively for sure. And this, what impressed me in one of the earlier studies was the finding that, again, the vulnerable patients were the ones that were gaining the most from this kind of, the fragile patients, they were gaining the most from this. And it could be the difference. This training could be the difference for these individuals to be able to go to the grocery store and do the shopping, cross the street, because they would be in enough good shape to be able to do it if they had the training and otherwise not. So that would be my answer to that. I don't know of any study specifically in yoga or meditation, but I think that has a very soothing effect on people's mind. So I can't see anything wrong with doing it. The programs that I've mentioned are usually for 4 weeks. 6 weeks is more common. 4 to 6 weeks. Yeah. Sorry.
Unmute yourself.
Yeah.
In the chat, there have been a few suggestions from Professor Puneet there, Professor H. Ramesh, about carbohydrate formulations that are available in India. One of them is Carboload, Carbolar, and one of them is marketed by Hexagon Nutrition. And from Mexico, Dr. Alfonso Najar has said that they use fruit nectar, especially mango nectar, instead of maltodextrin. What's your thoughts on that, Prof?
Yeah, well, there could be hundreds of different formulations that could potentially be useful. The only thing I can say about any of those formulations, not having seen any data on them, there are a few things that you should look for when you choose your formula. Is that, first of all, if it's a commercial one, ask them for data, not just on gastric emptying, but their effectiveness. Are they able to bring down glucose levels post-operatively? It's a very simple one to test. And that will tell you that it affects insulin resistance post-operatively if you do a study on that. So safety and efficacy needs to be proven for that specific drink, because they are all different. And they may have completely different effects. So it's not just any carbohydrate drink, although, again, many of them may very well work. Safest way to do it is to use the drinks that have been tested the most. Then you know what you get.
I think, Prof, I will not ask you any more questions on the carbohydrate load because you've made it quite explicit. Yeah. Now, this is a very interesting question from Dr. Vandana, and I get a feeling she's one of the consultant anesthetists from the Tata Memorial. She says, I'm an anesthetist. How do you convince surgeons to avoid nasogastric tubes?
Oh, okay. Well, okay. First of all, show them data. Okay. Well, I'll tell you a little bit a story. It comes back to actually convincing anesthesiologists this time, but the principle is the same. I was once asked many years ago to go to Verona to talk about preoperative carbohydrates 20 years ago. And the surgeon who invited me was very concerned with the fact that the anesthesiologist were against this. They didn't want to change their fasting routines to begin with. So what he had done, and this is what I learned, he gave the most influential leading anesthesiologist the mission to talk about modern fasting guideline as a presentation before I came in and talked about carbohydrates. Big meeting, a lot of people, and he had just served him the literature. And of course, if you read the literature, there's no way you can interpret it in another way. So he stood up and said, it's time for us to change our guidelines and make them and bring in modern fasting guidelines. I suggest you do the same thing. And you gather a meeting and then have the most important surgeon give the talk and serve him the data. The data is in our guidelines. You can find them there. Because you actually get a lot of complications from using nasogastric tube routinely.
Thank you, Prof. Prof, the next question is from Dr. Ishan, whose question is, what is the role of lipid emulsions in the immediate post-operative intensive care unit setting to prevent malnutrition when patients cannot be fed enterally?
Okay, that's a little bit of a ball game outside of what we have been focusing on, but in general, lipid emulsions have several effects depending on which lipid emulsion that you're using. First of all, it's a way of providing energy, but then you can have different types of lipids that will have different immunological effects on the body. And I mean, that's a very big, complex question to answer, actually. But in order to get a more in-depth answer, I would recommend you to go to, in particular, the ESPEN guidelines on these matters for ICU, but also you can look at some of on the nutrition side for surgery. That would, I think. That's a whole different area of discussion, actually. I'm sorry, but I think that would be the most appropriate answer for this talk today.
Thank you, Prof. Yes. The next question is from Dr. Sudhi, who asks, how effective is ERAS for emergency GI surgery or gastrointestinal surgery?
Okay, to answer how effective it is, there are a couple of different reports. There was one study in particular in the UK, they have been trying to implement enhanced recovery for emergency laparotomy, and we've written the first part of the guideline, and we are on our way to do a more large-scale testing of that in due time. I think that what we're seeing overall is that in general, the principles when it comes to the intra and postoperative phases are reasonably similar, that you can employ that. It's not going to harm the patient, and most likely it's going to do the patient some good. These patients are not going to recover as quickly as an elective patient, is the experience from the data where people have done both in the same institution. But what is really different when it comes to ERAS for this type of surgery is that if you read the guidelines for the preoperative setting, that is where you can really get the most out of ERAS. Because this is going to be a very different way of approaching the patient. You're going to get highly qualified decision making early on, much quicker with everything to diagnostics to get the patient on the table, to manage some of the basic treatments that need to be put in place, etc. So that is really a very different type of organization from what I would say most hospitals still use today, where very commonly junior people with less experience are managing the patients early on, and the seniors come in often too late.
Thank you, Prof.
Yeah.
The next question is from Dr. Husam Balila, whose question is, when is it the best time to start feeding a patient after anastomotic surgery? Is there a specific time?
Well, we for colorectal surgery, that's a very bottom part of the GI tract. We feed the patients immediately after the operation. But so as soon as they wake up and they're lucid, we give them something to drink. And if they feel fine with that, we offered some sandwiches. And then if it's a morning operation, they can have dinner in the evening. That's fine. For upper anastomosis, I know people are less quick to go for it, but from what I've been seeing so far, when it comes to being quite aggressive with this, it doesn't seem to be that problematic, with the exception, and maybe you would know more about this, Dr. Barretto, is pancreatic surgery, where it seems to be a lottery almost. If it works or not to early feeding. Maybe you can add on to that.
Oh, yeah, we start feeding with clear fluids as soon as the first post-operative day, and then delayed gastric emptying will define whether we can continue the feeding.
Exactly. Yeah, precisely.
Prof, the next question from Dr. Mahendra Lal is a very relevant question to the Indian scenario. Is there any evidence on ERA's feasibility in primary healthcare settings in villages or country towns in underdeveloped countries, or less developing countries?
Yeah, well, I think our colleague is here referring to what would be a more classic old-time general surgical clinic in a small hospital in a rural area, I assume.
Yes.
Well, it's interesting. We're working and getting some support from the World Bank with primarily some colleagues from Africa, but also from Asia and Latin America, where we are just about to complete a proposal for what we feel could be used from the guidelines in this kind of setting. Now, saying that, we are extremely humble in realizing that certainly not I, but some of my colleagues would have a better understanding of that who are locally placed, that we may be far off from actually understanding what the situation is like. So we're just producing what would be a starting point for something that we hope can develop into a more appropriate guideline for this kind of situation. And eventually a way to help people train in this situation as well, using simple modern technology tools. But in principle, what we found was when we go through all the different elements of ERAS, many of them are not that complicated at all. In fact, it's about not using stuff that is completely unnecessary. It's about withdrawing things. It's about going back to normal things. It's not giving too much fluids, and try to look at other ways of giving analgesia instead of opioids. So we felt that most of the things in the colorectal guideline, for example, which is one of them that we worked on, is very likely to be used in this kind of situation as well. So it should be coming during this year. I'm sure we will have the publication out, and then the plan is that we will conduct a big survey to ask people if they think, what do they think is reasonable, and at the same time describe their sort of situation that they're in. And maybe that, we hope that would help us tailor this work in the right direction.
Excellent, thank you. We really look forward to that, Prof.
Well, we would, if I may, ask around if people are interested in taking part of this eventually. Maybe we can find a way to collaborate around that. I think that would be very, very fruitful for everybody.
Yeah, excellent. Yeah. The next question from Alexander Minich is, which particular aspects of ERAS, the ERAS components, are most important in elective urologic surgery, more specifically prostatectomy, partial and radical nephrectomy?
That is a very common question. This type of question, it could be for any kind of surgery, actually. And the answer is this. What is going to be most important for you as a clinician is what turns out to be the missing points when you do an audit of your processes. That is going to determine which elements are going to be most effective for you. So for an individual unit, it is impossible to answer unless we have the data. And that's been my experience from training hospitals all over the world. It's the same everywhere. But if you ask me in general, when it comes to the two things that usually stand out in general, very general terms, is fluid management and analgesia management, I would say. Those are the two things that in traditional care are causing the most problems, I think.
Thank you, Prof. Mahima Maniar, her question is, what about ERAS in patients undergoing cesarean sections? The only data that's published is on oncological gynae surgery.
No, that is not correct. Actually, we have a guideline for cesarean section that's been out a couple of years. So you could find it on the website.
Excellent. Thank you, Prof. Murad has asked, what's the role, or how does one apply ERAS in reoperative settings for a complication?
I would say, of course, you can't do, it depends on how emergent it is, but you may or may not be able to do some of the preparations that we normally could do. For certain, I would be cautious. Most patients that we reoperate are in some level of pain or some level of stress. I would avoid giving a carbohydrate drink to them, because the likelihood of their stomach being compromised when it comes to gastric emptying is fairly high. But apart from that, I think we would go ahead and do pretty much same thing.
Yeah. Prof, there are a few questions coming up about wanting to know how to train in ERAS. Is there a specific site or any specific advice that you'd like to give?
Yeah, we offer training actually, and we have, in fact, we have just finalized the first hospital in India to be trained and qualified in gynecologic oncology and colorectal surgery, and that's the Manipal Hospital in Bangalore. And we are looking and hoping that we can widen up and spread that in different parts of India. So if you're interested in looking into how we're training, we're doing it in our way. There are other people doing it in different ways, but we like to do it data driven and with the team and everything that I've explained. So if you're interested in that, you are more than welcome to go to our website, and we can feed you with the information that you need.
Excellent. Dr. Soumya from Lucknow, India, has a question as to what's the data from the Asian subcontinent in terms of application of the ERAS protocol. Does the epidemiology, ethnicity, and socioeconomic background play a role?
We have the one thing that stands out is actually when it comes to the Asian population, same in Singapore and Philippines and Taiwan, it is the use of anti-thrombosis prophylaxis. It's done differently there, and it doesn't seem to be a big problem. So that's the one thing that I have been seeing. Apart from that, things are working very, very well with implementing ERAS wherever we have done it, actually in the Asian countries.
All right.
Same
Thank
in
you,
China, by the way. Yeah.
Thank you, Prof. The next question is a very interesting one. It's from Saji, and he asks, what's your advice to improve preoperative albumin levels on a catabolic cancer cachectic patient if there is time to optimize them preoperatively and the patient is able to eat adequately?
Yeah, I think this kind of patient would probably be a candidate for immune enhancing nutrition on top of, I think that would be the most immediate, simple way to move things forward. When it comes to albumin levels, I think one thing that is very often forgotten is to look at the cardiac status of that patient, because it may very well be that more prominently so, I would say post-operatively, but even pre-operatively, if the patient has any sort of cardiac insufficiency, that will also dilute the albumin. But in this particular patient, I would certainly give additional nutrition on top of eating. When you look at the literature for this kind of question, it comes across that these patients are not fulfilling their protein or their energy needs normally. They are usually below, but the addition of just oral nutritional supplements is usually sufficient to get them over the hill, and that will, in a couple of weeks, well, for immunonutrition, you usually, the data is usually for about 10 days. But if you have more time, that should be another option. Keep it on for a bit longer.
All right. Prof, there are quite a few more questions to go. If you want to take just a break and have some water, I think we can certainly give you those few minutes.
Yeah, I'll just
seconds.
have just a drink. Yeah. I'm good. It's fun.
Good. The next question is from Rudra Acharya. He asks, is there a role for partial peripheral nutrition in surgical patients?
Oh, yes, there is. In the case where they are not, where they're not feeding themselves properly, the guidelines today are saying, you know, if you're not covering your nutritional needs by day, I think the Americans are saying 5 days, Europeans are saying 7 days. then you should start adding peripheral nutrition on top. The jury is still out exactly when you should start doing this. I know there's data coming out for the compromised patients where it seems like it's a good idea to do it early, but that's still not published. But I think there's something underway in this direction.
Dr. George, you can take the questions from the audience. There are 2 hand raises there.
Yeah, Doctor, we've got 70 questions in the chat room. Dr. Gupta, N.M. Gupta, would you like to ask your question? Dr. Kamal Ali, would you like to ask your question? All right, I think we'll move because of the 70 questions. We'll keep moving. The next question is from Dr. Ravi, and he says, what is the role of ERAS in esophagectomy, especially in the context of early removal of Ryle's tube and oral intake on the 2nd day?
Well, again, ERAS has changed a lot of things in esophageal surgery, and the guidelines are out there, and again, they're available on the website. Certainly, this has changed practice quite a lot, and I think that most units that are practicing good ERAS are early in their feeding. But to be frank, off the top of my head, it was some time since we wrote that guideline. I don't remember exact the day. I would have to refer you to the guideline. I'm sorry.
That's fine. I think Dr. Kamal Ali's hand is back up. Would you like to ask your question now?
Dr. Kamal Ali, you are unmuted. Please go ahead. No, George, you can continue.
Yeah, so the next question is from Dr. Isba. And Dr. Isba's question is, what is the difference between early and late mobilization in preventing post-operative intestinal adhesions?
I don't think it, I haven't seen any data to show that earlier or later mobilization has any impact on that specific complication. But we try to mobilize patients the same day of surgery. That's our general principle.
Dr. Bimlesh Thakur has put his hand up. Would you like to ask your question? I think I'll move on with the chat. Dr. Vijay Borgaonkar's question is there any role for preoperative arginine-rich supplements?
Well, that's part of that is part of the immuno-enhancing nutrition, so where it plays a role.
All right. The next question from Dr. Mukesh Rundla is there an ideal time for preoperative antimicrobials?
Yes, the IV should be given within 1 hour before the incision.
All right. Dr. Suraj's question is, does the ERAS protocol get modified based on the surgical approach, whether it's open or laparoscopic colorectal surgery?
Yes, it does. For open surgery, we recommend thoracic epidural as a prominent choice, which we don't do for laparoscopic, for example. But otherwise, in general, it's pretty much the same. We're finding that with laparoscopic surgery, it's easier to run the ERAS protocol in general, probably again because of the reduction in stress.
Excellent. The next question is from Dr. Adele Choki, and the question is there any indication for a CT with oral contrast after gastrointestinal anastomosis before starting oral feeding?
No.
That was a quick one.
Yeah.
Dr. Vandana Agarwal, who had asked the question earlier, she's a consultant who's at Tata Memorial, who's very actively involved in ERAS, and her question is, how can we collaborate?
Oh, the best way that's why we put together teams. You should join us and I will teach you how to do this. We get the surgeons, anesthesiologists, the leading people and nursing staff together in a team. Everybody sees the whole data set, everybody gets involved, and you start working on a regular basis. We have meetings during the training weekly, actually, for an hour or so. And then we together we drive change. We find out what's going on. We find out how far away we are from the ideal protocol, and we realize where we have problems and what kind of problems we have, and everybody sees it. And then with our combined knowledge in physiology, pathophysiology, and knowing our own treatments and treatment choices, we can then come to a conclusion on how to drive certain changes, and we do that in a very systematic way. And we make sure that everybody who's involved at the different stations are aware of what they're doing now, what we want them to do, and how well they're driving the change by feeding back all the time. And this is how we drive change. And it really, all you need is one surgeon with you. If you get one out of a whole group of surgeons, and just the rest agree that they are willing to share, to have their data recorded, then you can drive change, and that will change. I guarantee you. I've seen it so many times.
Would you recommend them to get to the ERAS website and
yes, please
contact
do.
you via that?
Yes,
Okay.
yes, please do.
All right. Now, this is a question for Professor Baiju. There's a question from the audience about going through some of the guidelines again. I think this session is recorded. Would this be available to the participants later so they can go through the...
Yeah, it will be available on the YouTube channel of Senadhipan Education Foundation. It is free.
Excellent.
You'll have to just
Excellent. All right.
Shall I make a point?
Yes, Manish?
Sir, I'm really surprised no question was asked about that. Can we improve the patient profile so that the ERAS compliance becomes better? What I'm precisely talking about is, can we prehabilitate the patient?
Yes, I think prehabilitation has a role here, and I think they go hand in hand. It's about strengthening the physiology and the stress resilience of the patients by the means of prehabilitation. In fact, I just published with Franco Carli a review on the topic in British Journal of Anesthesiology. So you may want to, there we spelled it out, the whole story of why these things work together. But the answer is yes, you can do that. And I think, at least for the part of recovery, I think the data still needs to get a little bit stronger when it comes to complications, but I would be surprised if that's not going to happen.
The next question is from Amina, and the question is, what is the best fluid post-operatively for most surgical operations?
Balanced salt solutions is what we recommend throughout. We try to avoid using 0.9 sodium chloride, because that tends to result in water and sodium accumulation, which is not healthy for the patient. So, and we try to take the drip down, actually. From certainly the morning after the operation would be the latest that we normally would keep it in. But balanced salt solution, Ringer's lactate, something like that.
Because the person in the comment mentions G/W, and I'm hoping they're not saying glucose water, because 5% dextrose wouldn't be recommended.
A 5% glucose solution is going to give the patient fluids that will spread all over the body in every water compartment. Whereas if you give us a balanced salt solution, the likelihood that the most of the water is going to stay outside in the extracellular compartment. So it all depends on, and if you give a colloid, then most of it will be in the vascular. So you know, this is what you need to think about when you start giving your fluids. If there's a general very severe dehydration, then maybe what you're suggesting could be something to use.
Dr. Murad has, sorry, Prof.
Yeah, no, go ahead.
Dr. Murad has his hand up. Would you like to ask your question?
Hello?
Yeah,
Hello?
please go ahead.
Hi. So my question follows the last response by Prof. It regards fluid in neonates and infants. The practice where I practice, the anesthesiologists usually give 5% dextrose so that the neonates or infants don't go into hypoglycemia. I don't know. I'm not sure if that practice is appropriate.
Okay, I have virtually no experience from premature infants. So, but from a basic physiological point of view, let's put it like this: I would question that. If you're trying to avoid hypoglycemia, it has to. I mean, to give that kind of fluid, you want to get more fluid into the body as well. You just, yeah, I'm not going to get into that, I think, because it's not my field, really. But you should, there's a really good book by Dilip Lobo and Simon Allison that you can get through, I think it's B. Brown that sponsored it. They won the prize of best medical book in the UK a few years ago. It's about fluid balance, and that will give you the basics for everything you need to know. So I would look at that. Dilip Lobo is the name. Simon Allison. You're muted, sorry.
Yeah, the next question is, what's the evidence on ERAS in trauma surgery?
We have some data on emergency surgery, but trauma surgery, very little, very little.
Okay, Mehran Ahmed's question is nicotine as a colonic prokinetic recommended after surgery in the ERAS protocol? And how would one deliver nicotine to patients? Is it by using a patch?
We don't typically recommend it, but it may, I don't know. Again, you would have to look at, again, Lobo has done some good work on this one. There's a study I quoted by Bragg et al. That will give you if nicotine has any effect. I'm not sure. It doesn't have a very strong effect as far as I know.
All right. The next question is from Bimlesh Thakur, and it is, what is the role of feeding jejunostomies in esophageal and pancreatic surgeries?
Yeah, it certainly has a role in the sense that it would be a way of securing that you give nutrition distal to the sensitive anastomosis that have just been put. Again, it's not my type of surgery, but in general, we don't recommend this as a routine. But then my colleague here would know more about that for especially pancreatic, I think.
Yeah. So, I mean, our experience with feeding jejunostomies. So with esophagectomies, every patient gets a feeding jejunostomy. Whereas with pancreatic surgeries, it's more for the extremely concerning pancreatic anastomosis, where one would consider there would potentially be issues and delays in feeding. And here there's a toss-up between whether you're comfortable putting a nasojejunal tube at the time of surgery or a feeding jejunostomy, accepting that the nasojejunal tube is quite irritating to the patient and they really wouldn't tolerate it for a long period of time after the operation. So in really concerning very soft fatty pancreas, there's an option to put a feeding jejunostomy tube. We have a paper that's just been published in Pancreatology, which would be worth looking at, with Dr. Deeksha Kapoor as the first author. So yeah, worth looking at that. The next question from Mumtaz is, how early would you start an oral diet in gastrojejunal anastomosis in gastric outlet obstruction?
Well, these are getting into very, very specific issues where I'm a colorectal surgeon. That's what I've been doing. And so I find it hard to get into some of these details. I must be frank. I think I'm not the right expert for specific patient subgroups with a specific. I'm not the right one to answer. I'm sorry.
That's absolutely
Maybe you
fine,
can. Yeah.
That's absolutely fine. I think with gastric outlet obstruction, again, one has to be mindful that they have gastric outlet obstruction, and the stomach is going to take some time to recover.
Yeah.
So certainly testing with clear fluids and seeing the tolerance would be a way to go, and be ready to shift to, if you can't really initiate meaningful feeding from a caloric point of view within the first 5 days, then you have to start thinking of the parenteral nutrition and getting a PICC line into these patients. The next question is, what is the role of ERAS in bariatric surgery? I think you have alluded to this, Prof.
Yeah, it's there is a protocol, an updated guideline just published in World Journal of Surgery, and I think bariatric surgery in general is developed very differently in different parts of the world. I know back here, where they have had an interest in this for a long time and been very progressive, very, very rarely the patient stays more than one night. But I do know that there are centers that, they have to keep the patient in for 3, 4, 5 days, and are much slower in actually pushing for recovery. And I think that that's where ERAS can play a role. So check out the new guidelines. They're brand new, just came out, I think, this month.
Thank you, Prof. Dr. Kamal Ali's question is, what is the effect of post-operative drains or intraoperatively placed drains on ERAS?
We try to avoid routine use of drains. We don't see that they play any significant role. Very selectively that's being used actually and recommended. They're just a hindrance for the patient to get out of bed, and they make him feel sicker, and they are not very good at actually performing the job they're supposed to do. That is to tell us if there's something crazy going on or something dangerous going on.
The final question is from Dr. Alexander Minich, and I think we've spoken about preoperative carbohydrate loading a lot. And his question, which is a bit specific, and that's why I will feel this one, is in the morning, so preoperative carbohydrate loading in the morning in a diabetic patient will prevent insulin resistance, but in the same time can increase glucose levels, and anesthetists are afraid of this. How do we convince them to use carbohydrate?
Well, thank you for bringing up the carbohydrate treatment in diabetics, because that is an issue where frankly, we don't have a lot of data to give a firm recommendation. And that's why we so far have been, let's say, cautious in that recommendation. What we have available is studies on gastric emptying using, again, the drinks that have been tested. This is extremely important, especially for these patients. You can give the ones that have been produced here in Europe without going into any detail about them, with the normal morning medication, whether it's insulin or an oral medication. But you have to give that at the same time. Then what you will find is that they will have a slightly higher rise in glucose, but it will come down nicely, and they will empty the stomach at the same rate as a healthy volunteer of the same category, a matched healthy volunteer. The other thing we do know is that from some studies where diabetics have been included in more general studies, there has been no harm reported from them giving it this way. So if you're going to give any carbohydrate loading, first of all, check which drink it is. Secondly, give it with an oral morning medication. But then again, if you choose something that has not been tested and it's a low glucose containing drink or something, it may be an overkill to give the morning medication as well. So see what I'm saying? This is, you have to be careful with these things. But when it comes to gastric emptying, I think we can safely say with some reasoning that there seems to be enough, seems to be a possibility that we could start using it in diabetics, but we need more research. It's not a finished question. It's not answered completely.
Excellent. Thank you very much, Prof. And yeah, that actually brings us to the end of all the questions that are there in the chat.
Okay. Wow. A lot of interest. That was fun. That was really amazing.
Thank you, Prof. I'll hand it back to Professor Baiju and Manish from here.
Thank you,
Thank you.
Dr. Barretto and Prof.Olle Ljungqvist for the wonderful talk and wonderful moderation too. Actually, the talk was very lucid, excellent, and it was actually very informative. And this will be uploading in the YouTube channel of Senadhipan Education Foundation. As Professor was telling, if anybody wanted to collaborate with the ERAS, can visit their website, or you can ask me his email address. I'll be handing over to them. Please feel free to contact us. And I thank Dr. Monish for introducing me to Dr. George Barretto, who introduced Dr. Olle Ljungqvist to us. It was actually wonderful. You can see the participant limit. Actually, we had more than 500 participants. We couldn't accommodate more people here. Probably the YouTube link will be helping the people who are not able to join. Thank you once again, Professor, and we request to your
Thank you
in the future endeavors of Senadhipan Education Foundation.
Thank you very much. I would be very keen to see some follow-up on this. That would, if you could provide it, would be very interesting to see, because we're on a mission here to try to help as many people as we can, and it'd be very nice to see the effectiveness of this collaboration that we just started.
Yeah, sure.
Great talking to you guys. Thank you, George, for a nice conversation, and thank you for inviting me. It's been a pleasure.
Thank you. Thank you, sir.
Thank you, sir.
Good night.
Okay.
Good night.
Bye-bye.
Bye-bye. Bye.